blockages. Okay? So let's talk about those worst blockages. We'll talk about ischemic heart disease. So before we get into the classic discussion of arteries causing chest pain, let's talk about this dude named Prince Metal. So Prince Metal lived in the, I think, late 1800s, early 1900s. And he wrote a paper where he noticed that there were some patients who developed chest pain, and instead of having ST depression with their chest pain, they had ST elevation, right? This is the ST elevation that he saw. Now, why would that happen? Usually when you have pain at rest or pain with exercise, you have ST depression, and you only have ST elevation when you have an acute MI. But here's a subset of patients who had ST elevation when they developed their chest pain, and they weren't having an acute MI. That's what he described in his paper. Later, when catheterization was developed, we saw that there's a subset of patients, by the way, who had coronary spasm, where the artery would spasm and cause ST elevation on the EKG. And then we put 2 and 2 together and we discovered that Prince Metal's angina, which is chest pain at rest, is really just a ST elevation at rest because of coronary spasm. We treat this with calcium channel blockers, and that's usually adequate treatment for these patients. Let's talk, though, about the classic coronary artery disease. Now, remember that coronary artery disease is a continuum of conditions. At one end, and the end that we hope to have our patients at mostly, is chronic stable angina. This is where you have no chest pain any day of your life except when you're really stressing your heart. All right? You're outside chopping wood, and 3 hours into it, you develop some angina. That's perfectly acceptable. That's not an acute MI. You have exertional angina at a very high level of exercise. I had a patient once, 20 years ago or so, who had chest pain while he was biking, and it never happened before mile 20. So he would ride for 20 miles, have chest pain, have to rest for a couple of minutes, and then he could keep riding and be fine. That's chronic stable angina. Okay? Chronic stable angina, where you're going to have chest pain with only super heavy exertion. And you could even predict it too. These patients can be managed with just sublingual nitroglycerin that they take before they're going to do some activity. That's the best that we can hope for when somebody has coronary disease. When we get into the acute coronary syndromes, we're talking about unstable angina and acute MI, which we now term non-ST elevation MI, or for acute MI, ST elevation MI. Okay? So unstable angina, or NSTEMI, is characterized by patients who were doing fine, thank you very much, and not having any angina. And then a couple of days ago, they started having some chest pain with exertion. And now this morning, they woke up with chest pain. Well, that's an increase in their symptoms. And now they have rest pain. That is, by definition, unstable angina. Okay? Chronic stable angina, only with exertion. Unstable angina, now it's new chest pain, or it's increasing in frequency, or now it occurs at rest. Those are the indicators of unstable angina. And then, of course, an acute MI is you wake up with chest pain, crushing chest discomfort, heaviness, pressure, tightness, feels like somebody's standing on your chest. Go to the emergency room, do an EKG. There's ST elevation in contiguous leads. Now you have to go to the cath lab and get a stent. All right. So chronic stable angina, we can often treat with things that lessen the demand, right? We either have demand that we can deal with or we have supply. Well, the way to fix the supply side of the equation is to increase coronary blood flow. How do we do that? Well, we fix the blockage or we do bypass. So dealing with the supply side of the equation is done in the cath lab or the OR. We can deal with the demand side of the equation by using drugs like beta blockers. Beta blockers, the world's greatest drug. What do? They do all the opposites of adrenaline. They decrease contractility, they decrease heart rate, they decrease blood pressure, they make the world a better place. Nothing better than beta blockers, right? They hurt nobody, almost nobody, and they are just the world's greatest drug. Use them instead of calcium channel blockers 100% of the time. Wonderful drugs. We can also use antihypertensives, vasodilators. Those things will also affect the demand side of the curve. Okay? So when we have somebody with chronic stable angina, we can give them nitrates for use when they're about to do something that they know is going to cause them chest pain. I had a patient the other day who had inoperable disease we were going to manage medically. And I said, so what sort of activities give you chest pain? He said, really the only thing, he was an elderly guy. He said, really the only thing that bothers me is when I walk to the mailbox or take out the trash. And I said, good, then here's the way we're going to do it. If that's the only time that you get chest pain, take a nitroglycerin 2 or 3 minutes before you do that. And I saw him back in the office. He said, that was the greatest thing he ever told me. He said, I have no pain now because when I'm going to do something that I know gives me chest pain, I just take that nitro and I'm good to go. So we can treat chronic stable angina by treating the demand side of the equation, lowering contractility, lowering heart rate, decreasing wall tension with nitrates and beta blockers. The acute coronary syndromes happen when there's a plaque rupture, right? Now we can have dramatic plaque rupture where everything falls right into the vessel lumen and that because that fibrous cap erodes through, or we can have sort of a slow leaking, right? When it slow leaks, that leads to non-ST elevation MI. When it abruptly leaks and all that clot forms in the vessel, that's an ST elevation MI. That's the way we think about it anyway. We don't know. That's just the model that we use to think about this. When we have an MI, it eventually looks like this. Now, the only way we get this picture is when everything has gone very badly for this patient. I flipped this picture upside down because for some reason they published it upside down. This is the posterolateral wall, and this is where the infarct was. And you can see some damage in the form of this increased redness and inflammatory zone around the ischemic area. This yellow part, the pale part, is the ischemic area from an old MI. So remember that when we have myocardial infarction, we go through these stages that we can see on the EKG. The first stage that oftentimes we never get to see because it disappears within 15 minutes is these giant T waves, right? We get giant T waves in the affected leads as the very first EKG change. Usually it's gone by the time they get to the hospital, but in retrospect, sometimes we look at the initial EKG, and I've seen this happen before. When I was a brand new nurse, there was somebody in the emergency room who came in. I would have sworn that he was having a heart attack. We did an EKG and didn't see anything. The emergency physician didn't see anything. And then he continued to have chest pain. We repeated it, and he had this ST elevation. When the cardiologist came in, he pointed out that the patient on the initial EKG had these giant T waves, or what we call hyperacute T waves. and they had been missed by the emergency physician. I mean, patient did well. Everything was fine because he got thrombolytic back then, but still a little embarrassing, I think, for the emergency physician. After that 15-minute interval where you have the hyperacute T waves, then the ST elevation occurs. The next thing that develops within 24 hours or so is a Q wave. And as the Q wave develops, now the T wave also gets inverted. And then the ST segment starts to come back to normal. And eventually, after 48 hours or so, you'll have a Q wave and an inverted T wave. And this is how we tell that this is an infarct of indeterminate age. It could stay like this, from the 48-hour period until years later or for the rest of the patient's life. We just don't know how long it has been that these occurred, right? The T wave will come back to normal, maybe, at some point. And when we see a Q wave and a normal T wave in those leads, then we can say that this is an old MI. When we still have the inverted T waves, we say it's an infarct of indeterminate age. Once the T wave goes back to normal, then we can say that it's an old MI. Okay? When we see persistent ST elevation like this that never goes away, that's associated with an aneurysm. We don't see that very often anymore because we usually fix these patients pretty quickly after they present with chest pain. Now, how do we use the laboratory values from cardiac enzymes and other blood tests? Well, when muscle dies, it releases the contents of the cells, right? Because there's no apoptosis that happens during this. During an acute MI, the cells burst open because the sodium-potassium pump fails. The cell swells, they burst open, and out comes all of the globins, right? The first one, because it's the lightest of all, is myoglobin. Now, the problem with myoglobin is that it's not specific to cardiac muscle. All muscle in the body has myoglobin. So if the patient comes into the emergency room and their serum myoglobin is elevated, it doesn't tell us if it's their heart or they just ran a mile and it's their thigh muscles that are the problem. We have to wait for more specific labs like troponin and CK. But the cool thing is, if somebody comes in within 6 hours, right, because this myoglobin peaks at about 6 hours, if they come in and they come in with this crushing chest pain, we don't see elevated myoglobin at 6 hours, then it's not a heart attack, right? It's not a heart attack. So that was the way that we used to deal with it when we only had CPK to deal with as well. But now that we have troponin really peaks pretty quickly at about 12 hours is when it comes up more rapidly. It peaks at 24 hours or so, and then it comes down over a period of about 7 days. CK used to peak at 24 hours and come down by 48 hours and was gone by 60 or 72 hours. We use these to help us understand how old the MI was and how big the MI was. We look at the area under the curve here, and that tells us the total CK the total troponin spill, and that tells us how big the MI was. Does that make sense? So that's a little bit about how we use the cardiac enzymes at the time of an acute MI or unstable angina. Now, remember that this is just another explanation of the process that happens with acute MI. There's this atherosclerotic plaque, the lipid-rich core a thin fibrous cap holding it all in somehow ruptures because of shear forces, inflammation, or what have you. When that ruptures, the schmutz comes from that rich, lipid-rich core and moves into the vessel lumen, where it stimulates the platelet aggregation and blood clot formation. When that happens, there's an abrupt decrease or cessation of coronary blood flow, and that is either unstable angina or acute MI.